Hello, everyone. We are here to discuss the Concurrent Review Module for Locator. My name is Pat Lincourt. I am the Director of Practice Innovation and Care Management. And with me here today,
Connie Burke from the Division of Outcome Management and System Information.
So we are ready to roll out officially the Concurrent Review Module of the Locator, which has been available in the tool since December 1st. We have completed our training around the state, and we are ready to officially recommend that you start using the Concurrent Review for all changes in level of care, for reviewing either for internal reasons or because you're working with a payer to do a concurrent review with or utilization review with them. So beginning on April 2nd, we are officially launching the concurrent review module. So this training here will be, we're recording so that new people coming on who are using the tool who weren't able to get to any in-person training sessions will be able to view this and learn how to implement the concurrent review module. So we'll be walking it through today, and welcome everybody.
Thanks, Pat. So what we'd like to do first before we actually go through a walkthrough of the tool is to talk about how the concurrent review module is structured and what you can expect as you move through the tool. So the first thing that you'll find when you select to do the concurrent review module is to answer what level of care the person is currently residing in. So the way the tool is set up, you actually will be responding to the same type of questions, the same criteria, if you will, that rendered the person appropriate and eligible for the level of care that they're currently in. So you're really assessing whether or not they still need that level of care, hence needing to indicate where they are right now. The next question you'll see is with regard to a change in status. So right away we ask if you know that the person is in need of a higher level of care, you can indicate that, and that will then result in you completing the Locator 3.0. So you'll jump out of the concurrent review and you can go ahead and determine what the appropriate level of care should be. After responding to the status change question, we go through a few questions asking about withdrawal urges and or cravings. So we are very much in support of the use of medication-assisted treatment to address these concerns that people have, and we certainly recognize that it's important to make people comfortable and to ease up these urges and cravings in order for them to be able to focus on treatment. So we have a special section just for this issue. So you'll see that there are 4 questions that are included in this section. We ask if the person is on medication-assisted treatment. We want to know if there's a plan to continue medication-assisted treatment at the next level of care, and if the person's experiencing urges and or cravings to use. If, in fact, you say yes, then we want to know if the treatment plan includes strategies for managing withdrawal and cravings. So these are all things that you should be thinking about and including in the treatment for the individual. After talking about the withdrawal urges and cravings, we go on to a set of questions that will determine if the current level of care is appropriate. So for the purposes of this demonstration, we use inpatient rehab as the example. So if the person were currently in inpatient rehab, the questions you would see include, does the person have serious medical symptoms that are not stable and continue to need to be managed in an inpatient rehab setting for the SUD treatment to be effective? We ask the same question with regard to psychiatric symptoms. And then we also want to know if there is a risk of substance use in hazardous situations in amounts or frequencies that are likely to cause severe physical or emotional harm to self or others. Now, these were the questions that were responded to affirmatively that rendered the person appropriate for inpatient rehab. We revisit this criteria, and in responding to these questions, we want you to think about what the situation would be like if the person were no longer in that level of care. So while they may be addressing their medical symptoms in the current treatment setting, you need to think if, in fact, the treatment setting was removed, how would the person be managing? How would they be able to cope? So you should consider without the treatment setting what would happen to an individual. Pat, do you have anything else you want to say about those questions?
No, I think that you have the main points there kind of being around whether or not and so you can see how it's worded a little bit differently than the original locator, but the points of what had qualified that person for or recommended that person to this level of care in the first place are still the same kinds of questions that we want to revisit. Of course, people may have some remission just by virtue of being in that setting. So the question is more about are they doing better because they're in that setting? If they were to be discharged, would they completely revert back to the original? Or have they learned some things? Have they better managed their medication so their medical symptoms are stabilized, their psychiatric symptoms are not just remitted because they're in a safer place, but they've really learned some skills or their medication has been adjusted? And then the issue of hazardous situations and use. You can never predict wholly what a person is going to do. But the question here is, if you remove the person from this level of care, is it likely that they would go right back to the original situation that was causing the hazard? This question has, people have had some questions about it in the admission locator, as well as now here in the concurrent review. That hazardous situation, all substance use is hazardous to some degree or another, but we're talking about here amounts or frequencies that are likely to cause severe physical or emotional harm, something that may be life-threatening or at least seriously impacting the person, and that risk is very imminent, that if that person were discharged, that you would be very concerned that they would use in a way that would harm themselves very soon after that discharge as well.
So after responding to the questions with regard to the current level of care, the tool will give you a determination as to whether or not the person is still appropriate for that level of care, or if in fact they're not, you'll be given the option to complete the Locator 3.0 to decide which setting would be appropriate for them. Once you go through those steps, you'll next go on to the good care questions. So here we have questions that we want folks to be thinking about and responding to in terms of the type of care, the quality of care that individuals are getting in the treatment program. So the questions include, have goals and treatment methods been developed in partnership with the person? This is critically important in that we want to be providing person-centered care. We recognize the importance and the value of the person's voice being represented in the treatment plan and their voice being included in terms of determining goals for themselves. Is discharge planning occurring is our second question. We all know that it's important to be thinking beyond the current setting and what would the next step be for the individual. We ask, has the individual's commitment to recovery been addressed with motivational interviewing? Motivational interviewing is an evidence-based practice that's very important and a critical tool to use in order to help people identify what their goals are and what they would like to include in their treatment plan. And then we ask, has trauma been assessed to inform treatment planning? We recognize that there is a high percentage of folks in our system who have experienced some form of trauma, and we know that it's important for us to address that trauma in order to help them move towards their recovery goals. So we'd like you to be aware of these different aspects of treatment, and these are things you should be including and thinking about in terms of your service provision. After talking about the good care questions, we go on to another section that covers treatment planning needs. Here we ask if the person's been screened for psychiatric symptoms. If you were to say yes to this question, we would want you then to tell us whether or not there was a need for further assessment or referral. If yes, we would then ask you about that referral, whether the referral was made. So the purpose here is for you to think about what elements have been included in the treatment planning and think if there are any gaps in the treatment planning or any issues that haven't been addressed and should be addressed. Has there been an assessment of physical health needs? And again, here, if you were to say yes, we would ask if the health needs were further looked into and if a referral was made. We ask if the person is in need of housing. In this instance, if you were to say yes, we would ask if you address the housing need, and then you would see a third question that asks about how that housing need was dealt with. Finally, we ask, is there a plan to connect the person to recovery supports? We certainly recognize the importance of having connections to people in the community who are supportive of an individual's recovery goals, and we want to ensure that that's an element that's being included in their treatment plan and something that you're thinking about. Anything else, Pat? Okay. So you'll see that there's some clear flow here in terms of how the tool is set up. Again, we look at the current level of care, whether there's a status change and someone needs a referral to a higher level of care. We recognize the importance of thinking through whether someone is experiencing withdrawal urges and cravings and the importance of addressing those. We then go on to determine if the current level of care is appropriate, and we include questions on good care and treatment planning to help you think through ways that we can improve the quality of the services that we provide and ensure that we're meeting the person's needs. Now we're going to go ahead and walk through an example in the system. Since the system's been open and up and available since December 1st, some of you may have already seen the Concurrent Review Module. With that, you'll know that you have the same patient identifying information screen as appears in the original Locator 3.0. The tool is set up similarly in that it's a matter of pointing and clicking, and you have pull-down menus you can use to respond to questions. And you now have the option to select either completing a Locator 3.0 for admission or completing the Concurrent Review Module. And actually, Pat, maybe now would be a moment for you to explain when people should be doing the Concurrent Review Module versus an admission.
So also, we have available the Concurrent Review Manual, and we would really encourage people to read that manual. One of the things that it will talk to or speak to is at which point in treatment you should be completing a locator, and whose responsibility it should be in an ideal world to complete the locator, and how providers should communicate with each other around completed locators. So just for an example, we'll talk about somebody who may be transitioning from outpatient to detox and then working through, you know, a number of changes in level of care. Say the person came to an outpatient clinic and were assessed to be in need of detox, and a locator was completed to determine the level of crisis or management or detox services. That person was appropriate for a medically supervised inpatient. The outpatient program that has completed the locator to determine the level of care can pass that completed locator report to the medically supervised inpatient withdrawal service. They can utilize that locator. They could also choose to do another one if they clinically thought it was appropriate or that they wanted to, but they could also accept that locator. That crisis withdrawal program is then responsible to do a discharge locator to determine what is the best next level of care for that person. And they should be including that report into to the next level of care. So in this case, let's assume that it was an inpatient rehab. That person then, the inpatient rehab, in receiving that referral, could accept the locator report for admission to the inpatient program. They would be responsible while that person was in care to do a concurrent review if that was something that was needed for that person, a continued stay conversation with a plan to exceed the 14 days, which is encouraged when people need it. So people should be utilizing this tool, and there a relationship with the plan to ensure that people who are in inpatient rehab level of service can be continued if that's indicated by their clinical picture. That inpatient rehab will also do a locator toward the end of that person's stay that would indicate the next level of care. And then that locator could follow that person to that level of care. So say it's back to outpatient. Outpatient can utilize that locator to support services in outpatient, and maybe it's an intensive outpatient level of care. They could utilize that locator also for their notification to the plan that that person has been admitted to an intensive outpatient treatment. So that's the way, in an ideal world, this would work. What we don't want to happen is if a program doesn't receive a locator, that poses a barrier for that person to come into care. The locator should never be used in that way. So if a program were to be having difficulty obtaining that locator, they should go ahead and complete an admission locator at that point. The concurrent review is always used after an admission locator has been used, even if you think you're going to go back to need to re-enter. And we'll walk that through to show you that if you start a concurrent review and the level of care is no longer appropriate, you'll be looped back to the original page to begin again an admission locator. All of that identifying information will follow that person, but it's important for us to understand that it was a concurrent review rather than an admission locator at that point, and also for the payer or for whoever you're communicating with. All of this is laid out in detail in the manual, so you don't need to be expected to remember this at this point, but all of that is written out and in the locator concurrent review manual.
Great, thank you. So we're going to go ahead and select the concurrent review module option. And as you can see, we then need to indicate which level of care the person is currently residing in.
Why don't we choose rehabilitation and residential?
Okay. So here is the question with regard to a status change that would require movement to a higher level of care.
And we'll say no to that.
And now we want to know if the person has a diagnosis of an opioid use disorder.
And we will say yes to that.
Is the person on medication-assisted treatment?
Yes.
And now we want to know if the person is experiencing mild to moderate symptoms of withdrawal that are creating physical discomfort, cognitive impairment, and or emotional distress. And we also ask if the person is experiencing urges and or cravings to use substances.
And we're not going to check either of those. We'll assume that that person has been in rehabilitation in residential for a period of time and that those symptoms have subsided a great deal for them.
So Pat, is it possible that someone could continue to have cravings during this time, even on medication-assisted treatment?
Yeah, definitely. And so cravings in that case would indicate that you would check that box, and what the recommendation would be, it would be either to have that person reevaluated medically to make sure that the medications are as effective as they can be, or to reassess the medication or add something that might be helpful for cravings. But also to rethink through in a treatment planning way, if these cravings are distressing to the person or that they are causing distraction to treatment, that there's cognitive and behavioral strategies that can be employed and probably should be increased in the treatment planning strategy. People should be able to learn how to be aware and to employ those in substance use treatment altogether. The reason that it's here is that we want people to be reminded of that. Sometimes urges and cravings too kind of show themselves in behavior rather than in people really being able to identify what's happening. And so this is a reminder to check in for that. But yes, it could happen anytime, and it can happen many, many years after somebody has been, not using substances at all. That's why in the DSM, craving can be present even when somebody is in full remission from their substance use disorder. It's anticipated that people will have some craving over time. It's what happens, you know, to the brain when you have, you know, developed a substance use disorder.
Moving on, we ask, is there a plan to continue medication-assisted treatment at the next level of care?
Yes. And that's important. I mean, if you have, especially if you've initiated someone on a medication that's being helpful to them, if you've initiated them on a agonist for opioid treatment, or even an antagonist for alcohol treatment, you want to make sure that as you're making transitions in care, that that medication that may be helping them stay stable can follow that person to the next level of care.
Now we move on to the questions that are particular to the level of care the person is currently in. And we ask, does the person have interpersonal or personal skills deficits that are apparent in the residential setting, indicated by difficulty in relationships with peers or staff, difficulty performing roles as identified by self or community, or persistent disregard for social norms, rules, and/or obligations?
So the reason that somebody would have been directed to rehabilitation in a residential setting are the issues around interpersonal skills, roles, and also the ability to conform to a setting's expectations or rules. What you expect to see in a residential setting as a person, you know, as the program addresses some of those specific needs, is a reduction of symptoms. So these are lifelong patterns of behavior, and what you're looking for in rehab and residential care is changes for the better in those patterns. So one of the indicators that a person may need to remain in that level of care is that some of these patterns of behavior are actually present within the community in the residential program. You would check any of these that apply, and if they do not apply, you would leave them blank. So in this case, Connie, let's say that the person is continuing to have some interpersonal difficulties with other residents of the program and staff.
Next, we ask, can the person manage triggers for substance use when they return to their environment?
So we are going to say no to that this is a person who is having some interpersonal difficulty, and they also are not expressing a commitment or an understanding of what these triggers mean for them. So we're going to answer no to that.
Okay. And this, too, is a question, as you can see from the language, we're thinking in terms of when they return to their environment. So as we talked about earlier, when you're contemplating whether the person is still appropriate for the current level of care, you need to think in terms of if that level of care were discontinued, if the person were discharged, how would these symptoms, how would these issues, would they continue, would they persist, or would they be resolved? As you can see, the recommendation here is for the person to remain at the rehab residential level of care based on the information that we provided. So we're going to go on and demonstrate the good care questions and the treatment planning needs sections of the instrument at this point. So we ask in the good care questions, has the individual's commitment to recovery been addressed with motivational interviewing?
I would say yes to that.
Has a treatment plan been developed?
Yes.
Have goals and treatment methods been developed in partnership with the person?
I would say yes, and I just would make a point about this question is that this will be something that people will naturally agree with and say, yes, we have done that. One of the things that programs want to probably do is to think about how they're including that person. You notice that the word here is in partnership. So it's not just that the person has accepted the treatment plan or that they've been informed by it, but that the goals and treatment methods have been really discussed with that person so they understand. So if a person from the outside would come in and ask any of the residents in your program, what is your treatment plan, they would have some idea about how to answer that. They would know what their goals were, what they were working toward, and even some of the ideas about what some of the methods that are being used to get there.
And I really like some of the examples that we've heard in the trainings, Pat, with regard to this question, where people have indicated they actually use quotes, direct quotes from the person in terms of, like, in their own words, what they want to establish as a goal. You can't get more person-centered than that.
That's right.
So we go on to ask, which strategies are you using or do you plan to use to increase the likelihood the person will make the first appointment at the next level of care? So I want to point out that, as always, if you see any text in blue in the application, you can hover over that term, and it will provide you with some additional information or guidance around the term that we're using. As we look at this list, too, you'll see that it's very comprehensive with regard to the ways that you may try to link a person to the next level of care. So, Pat, do you want to talk a moment about why it's so important that our providers, link to the next level of care, and who kind of owns that process?
So transitions in care are very important. And one of the things that we know is that if people stay connected to care for 6 months or more, they tend to have better outcomes in treatment. One of the places that's very difficult, whether a person has decided to leave against medical advice or whether they're having a planned discharge, there should be some planfulness in terms of how they're transitioning out of the program, if that's at all possible. So in a rehab in residential, you would expect that this is a person who you would want to stay connected at some level, following that program. And attempts should be being made to make sure that that person is connected. I think that the responsibility used to be in a more siloed world on the receiving program. So you finished my program, I've given you a referral, it's on you and on that program to make sure that you get there. As we work toward more collaboration and a more system kind of approach to making sure that everybody's outcomes are effective, that there's good outcomes for each person in a more value-based kind of arrangements of that are soon to come, everybody will be accountable for how that person did, what the kind of outcomes they had, including whether or not they're continuing in care. So that would be something that programs will be focusing more on, is making sure that they're doing things to make sure that the person gets to the next level of care. And their partners who are those next levels of care should be working with you in order to achieve that as well. So here's a whole list of ideas. Depending on where you are in care and rehab and residential, because it is a longer period of time that people may be with you, you may be employing some of these, or you may not yet be. At least in the last month of care, you want to be, starting to think about how, what the person's needs will be, and engaging in some of these ideas about encouraging that next level of care to occur. So one of them is, introducing a peer who may, be very aware of the, the outpatient clinic, perhaps, that the person may be attending, or maybe it's a recovery program or a recovery center. So you would want to introduce that early on and help make that linkage. And so here you can check any or all that apply.
And I think another point to make about this list of options or strategies for linking folks to care is that you can think beyond the resources that are available within your treatment program, or even beyond what is available at the treatment program you're linking to. So you'll see that there's a transportation using resources from the program or a Medicaid cab or another resource. We also have included in the list a referral to the health home care manager or the managed care plan, using them in the transition planning and process. So it's important to keep in mind and be aware of the fact that there are other resources that are available even outside the treatment programs, and there are folks in positions who can help to facilitate that transition. Certainly any managed care plan assigns a care manager to an individual, and so you should be in communication and you should be collaborating with these other providers in order to better the chance that someone is going to make it to the next level of care.
So let's choose the option. I'm further away from the screen than you without, but about linking, having a peer become a bridge.
Sure. Okay. Is there an indication that the person experienced physical, emotional, or psychological trauma?
In so many cases where people are in substance use disorder treatment, that's true. So here we say any indication. You could be using a formal screening to determine that, or you could be doing something less formal, and either the person has reported it, or you see evidence in their behaviors and some of the things that they react to or that they are fearful of that to suggest that there is an indication that that person has had that experience.
So we'll say yes to this question.
Yep.
Has trauma been assessed to inform treatment planning?
We're going to say yes to that, considering where this person is in care, but you may have reason to say no to that. In this case, you would get a text box to just explain the reason for that, and that may be information that's useful to whoever is going to receive this report or to the payer to know that this is something to pay attention to for the person down the road.
So it sounds like, Pat, if someone were in detox, they may even in that time show some indication of trauma, but it's not the appropriate time or setting for the trauma to be addressed or even assessed, in which case we would say no to this. And as you said, we would then provide a justification or an explanation as to why the trauma is not being assessed at that time.
That's true, and I think that detox is a good example of that because people tend to be there in a very short time, but it may also be that one of the things, if somebody were a repeat person, that is getting in their way. So it's not, I wouldn't exclude anybody from addressing or assessing trauma and trying to identify some of the ways in which it's related to the substance use disorder, but yes, very often in a short-term period of time, there's not that a detox wouldn't have the ability to do that. And there may be other clinical reasons not to, and it's just this gives you the opportunity to explain what they are as well.
And what I'm thinking about as we have this conversation, Pat, is the fact that you absolutely need to be focused on the individual, on the person, on their circumstances when you're responding to these questions. So there's never a situation where you say, if it's X, it has to be Y in responding to questions. So as you just pointed out, detox, there may be reason to address trauma in that setting. I think typically folks might think that it's not the time to do it, as I just indicated, but in fact, you really need to think about the person and their specific situation and their circumstances and what the person's needs are, and you need to be responsive to those needs.
That's exactly right.
So we ask, has a trauma-specific intervention been included in the treatment plan?
And we'll say yes to this as well. Lots of programs have implemented evidence-based practices that exist to help people build skills. That would be especially true in this level of care because remembering that how somebody would have gotten here is that they're having difficulties being able to, function in their role or having interpersonal issues or conforming to rules. Trauma often is a factor in how somebody responds to these things. And so coping with the trauma, even understanding how it's been connected to the person's current behavior or feelings is really important to their being able to address them. And there's many ways to do that. There are some coping skills, there's some group formats, there's individual EBPs that are effective. So I would say yes to that, and there is a lot of clinical latitude for identifying what that specific intervention would be.
Has the person been screened for psychiatric symptoms using a validated tool? Here again is an example where we provide a definition of what we mean by a validated screening tool. So we say it's an instrument that has been psychometrically tested for reliability, validity, and sensitivity.
So, yeah, no, OASAS it worked with Nathan Klein Institute to develop, modify the mini mental health screening tool. And so the modified mini is one of the ones that OASAS has worked to help providers implement, but there are a lot of other tools out there that what you want is something that is broad enough to identify, you know, a range of potential psychiatric symptoms. And there's many to choose from.
So we're going to say yes to this question. We then asked, did the screening indicate a need for further assessment and or treatment of psychiatric symptoms?
We would say no to that. We're going to say that this person did not have a positive screen.
So we move on to ask, has there been an assessment of physical health needs?
We would expect that, yes, at this point in treatment, there would have been a thorough assessment.
Does the person have a significant physical condition that requires follow-up with a physician?
And we would say no to that.
We move on to the housing question. Has the person been screened for housing needs?
So we'd say yes to that. And this is a level of care that a person would have both the interpersonal and skills deficit, but also would not have had a safe place to go to a day rehab program for addressing those. They wouldn't have had the environment to support that. So it's very likely that a person who's living in a residential program and a rehab element of care would need housing. So I would say yes to that.
And then we ask how the housing need is being addressed. So you can see from this list that there are a number of options. We look at both permanent housing that's supportive of recovery as well as temporary housing. We also recognize that folks may move on to another treatment setting that provides housing. So we purposely developed this list to try to capture the nuances of the housing issue and the housing need that exists across the state, and also recognize that in some instances people would go on to a shelter, or they may have permanent or temporary housing that's not supportive of their recovery, that may not be safe. People make decisions for themselves in terms of where they will move on to, and we wanted to be sure to capture, you know, patient choice and in terms of going perhaps to a housing situation that is what they choose, but maybe not supportive of their recovery. We also include options like no housing options available in the area. This is a check all that apply, so we do want you to be comprehensive in indicating what the situation, what the nuances are of that individual's housing situation.
So this is a part of the concurrent review that we changed as we got lots of feedback from providers that housing needs are very complex and that there are areas of the state, in fact, in most areas of the state, there's some housing scarcity or difficulty in making the connection to housing, and we wanted both for providers to be able to convey what the issues are to the next level of care and to the payer, but also wanted for our own ability to look at the data that we get to identify areas where there are specific issues that you know, the state can take into consideration as planning is made.
So I'm going to say the person's been referred to treatment with the housing component. Finally, we asked, does the person have supportive people who care about his or her recovery, and this could include family, friends, self-help, or a faith-based community?
I would say yes to that.
Which brings us to the end of the concurrent review questions. You'll see that you received a summary of the information on the screen once you've completed all of your entry, and then you always have the option to download a PDF version of the results in that report format, and then you also have the option to download the comma-separated value version of the information that you entered. So Pat, I thought that we should walk through one more example and show folks how, if someone is not appropriate for their current level of care, just what it looks like when they make that transition.
Sure.
So again, we're going to select the concurrent review module. We're going to indicate inpatient rehab as the level of care. We're going to say, no, the person doesn't need a higher level of care. We're going to say no to the opioid use disorder. And next, we're going to answer as to whether the person is experiencing mild to moderate symptoms of withdrawal. We're going to say no to that. We're going to say no to them experiencing urges and or cravings to use. And then we're going to respond to the questions with regard to this particular level of care. We're going to say no, the person does not have serious medical symptoms that are not stable. We're going to say no to their serious psychiatric symptoms being unstable. And we're going to say no that they aren't at risk for use in hazardous situations if they were to discontinue this level of care.
And it isn't that they're totally not at risk, because remember, anybody who could potentially use is at some level of risk, but that the risk is low.
You'll see that this person no longer meets the criteria for continuing in this level of care, and you're asked if you'd like to go to the locator to determine the best level of care. We're going to say yes to this, and you'll see that you'll receive the summary screen for the CR module, and then have the ability to start a new locator. When you do this, when you select that option, you'll see that the patient information screen is pre-populated with the information that you had entered when doing the concurrent review module. And you would go ahead and select Locator 3.0 as the option to complete the determination on the next level of care. I'll stop there, Pat, because I think people are very familiar at this point with the Locator 3.0, but I wanted folks to see how the concurrent review module works in conjunction with the Locator 3.0 questions. Is there anything else, Pat, that you think folks should keep in mind as they work with the concurrent review module or working with it in terms of their relationship with the managed care organizations and communicating with them?
Just a couple things. The first is that sometimes we've heard people say in trainings that they get a level of care that is unexpected. And, you know, they can approach that one of two ways. One way would be to go back and to answer the questions differently to kind of get to the level of care that they did expect or that they thought was appropriate. We'd really rather have people answer the questions that to their, you know, clinical formulation are the accurate questions. And if they did get to a override situation, that they would then do form the clinical formulation themselves as to why. Remember, the 3 reasons to override. And the reason for that is that it's really important for us to both be able to evaluate the tool and how well it's working to get to the level of care that is the best for the person, and also for your own feedback. It may be, in some cases when we find this has occurred, that the person who's using the tool has interpreted a question in a way that it wasn't intended. And so if you are getting to a level of care that you know, have not expected, to talk in supervision, to talk with other locator users, to send a question to the pick-up mailbox, asking, you know, telling that you're getting this unexpected result, and how, you know, we would be happy to walk you through a locator to, you know, help you think through how the question, what the intent of the questions are. And it may be that there is something that the locator hasn't identified, and in which case it's perfectly okay for you to override that level of care. But we'd much rather you did that than to go back and to just try to get the level of care that you were interested in. And then the other point is related to that. It really is important to read the manual. And in this case, there are some client examples that may be helpful to you in answering these questions. And not just assume that you know what the intent of the question is because you've been to this training. It really helps you. These questions are meant to be brief and to help you move through it quickly, but there's a lot of nuance to, taking your assessment of that individual client and answering these questions based on that assessment.
Yeah, I think that, directing people back to the manual is really important, and actually it should be a starting place for people. I would really strongly encourage anyone, and even going back to the Locator 3.0 manual, we've built in the explanation, the intent of the questions, as Pat said, to help you understand the nuances and to kind of clue you in to what you should be thinking about when you're responding to these questions. We've included the skip logic, the skip pattern in the concurrent review module as we did with Locator 3.0, so you can understand how the tool flows and how the questions work with one another. And as Pat said, there are some great cases that are included in the explanations to help you understand how to respond to the questions and even question sets, because the cases will follow through sections of the manual. So I can't emphasize enough the importance of the manual. I also wanted to emphasize, and Pat has already indicated this, you always have OASAS as a resource if you have questions or issues with how the tool is working, or you're not sure how to respond to a question, or perhaps you have a particular case with an individual and you're not sure how you should be addressing it within Locator. You can always email the PICM mailbox, which is PICM at OASAS, I apologize, so PICM at oasas.ny.gov. The PICM staff are readily available and are very responsive to questions that come into the mailbox. You also, with regard to the Locator tool, and certainly if you're having any issues with your Health Commerce accounts or access, you can also use the Locator mailbox, which is Locator, LOCADTR, at oasas.ny.gov. If you mistakenly send a clinical question to Locator or an HCS question to PICM, we work very closely together, and we will work to make sure that the right person is responding to any question that you send in. And I strongly encourage you to tell others about the availability of this webinar on the Locator page, and also the availability of the manual on our page. So if you need extra copies, don't hesitate to download and print those as needed.
And then just a final closing thought from me, one of the things the manual stresses is also that the Locator recommends a level of care. And based on how you answered it, it's likely that that is the most effective level of care. But in no way is that to be used to deny people treatment in an alternate level of care that they're more interested or able to access. So the care should always be person-centered. If, say, inpatient rehab had been recommended for somebody, but they couldn't get there, or they wouldn't get there, and they refused to go, that doesn't mean that you can't continue to offer them services in an outpatient level of care. It does inform you that that person may need lots of additional resources around them to help make that treatment episode effective. And motivational interviewing may be utilized through that time to help them to, weigh the options and, and understand that inpatient rehab has been recommended as maybe the most effective place. But it should not deny a person access to care.
Great. So again, if you have questions, know that we're here to answer them, and we're here to help. I encourage you to look at the manual, make use of this webinar training. And I thank you very much for your time and attention today, watching this and learning about the Concurrent Review Module. And I thank Pat for all of her insight and her knowledge that she continues to share with us as we go forward in this transition in the field.
Thank you, everyone.